This video will focus on laparoscopy, a common gynecologic surgery modality. Here, we aim to describe the concept of laparoscopy and compare its major modalities. We will outline the components, setup, and use of laparoscopic instruments. Finally, we will conclude by discussing common medical student roles in laparoscopic cases such as operating the laparoscope and closing the port sites. Laparoscopy is a minimally invasive surgical technique that was introduced in the early 1900s to reduce complications of traditional open surgery. It is often called keyhole surgery due to the small incisions made. Interestingly, laparoscopy was first used to observe the abdominal cavity of a pregnant woman. And since its advent, laparoscopes and laparoscopic instruments have evolved drastically. However, the fundamental concept of laparoscopy has remained unchanged: to provide patients with a less invasive surgical approach to minimize operative complications and improve patient outcomes. Laparoscopic surgery comes in two flavors: laparoscopy and robotic-assisted laparoscopy. Both approaches begin with port assembly and placement. Where they differ is in their associated cost, surgeon positioning, dexterity, and visualization. Standard laparoscopy, sometimes referred to as straight-stick laparoscopy, is more commonly utilized in robotic due to its relatively lower cost. It involves the surgeon directly holding instruments, offering slight tactile feedback. It is limited by its 2D visualization and inability to manipulate instruments using wrist flexion and extension. Robotic-assisted laparoscopy is a relatively newer technology, allowing surgeons to operate at a console robotically, controlling laparoscopic arms located at the operating table. The robotic approach offers greater dexterity, with instruments allowing wrist movements, 3D visualization, and the elimination of physiologic tremors. Its drawbacks include higher associated costs, relative lack of tactile feedback, and longer setup. Next, we will discuss the various components of laparoscopy. A standard laparoscope at one end consists of a stainless steel shaft housing a lens train that allows for visualization. At the bottom of a laparoscope is a light post which connects a light cord from the light source on the laparoscopy tower. The end of the light cord can become extremely hot and is a fire risk, so it must never rest on the patient or surgical drapes. At the base of the laparoscope is a camera with buttons on top controlling settings on the monitor. It is important to keep the buttons up and level while manipulating the camera, as this controls the horizontal view, often referred to as the horizon. The buttons control light settings and ability to record or capture an image. If an angled scope is used, such as a 30-degree scope, spinning the light cord around the base changes the angle of view. This is the laparoscopic tower. It houses a CO2 insufflator, light source, camera, and electrosurgery power supplies. Atop the laparoscopic tower is a monitor for controlling settings and viewing the operation. Other essential components of laparoscopy are trocars and cannulas, often collectively referred to as ports. The ports form the connection between the external environment and a patient's peritoneal cavity and allow for surgical instruments to be introduced. Ports come in various diameters and can be metal or plastic. The cannula, also known as a port, is the outer sheath through which the trocar is passed to enter the peritoneal cavity. A trocar is a small rod-shaped stylet that is slid through the cannula to make the initial entry into the peritoneal cavity. In the OR, the word trocar is commonly used in reference to the fully assembled port. However, the technical definition of a trocar is a stylet that fits within the cannula. The cannula can also have an external port at the top to which the carbon dioxide gas can be connected to insufflate the abdomen. It is best to keep the carbon dioxide connected to a port that isn't being used by the camera or laparoscope, as the carbon dioxide connection can cause the view to fog. Abdominal insufflation with carbon dioxide is required for adequate visualization. Carbon dioxide is the gas of choice due to it being non-flammable and its ability to be systemically absorbed. There are two main methods for insufflation. Pictured on the left is a cannula with a carbon dioxide port, and on the right is a Varus needle. The Varus needle is unique as it contains a small ball atop a spring-loaded needle that allows the surgeon to know when they have entered the abdominal cavity. Both the varus needle and cannula are connected to the carbon dioxide insufflator located on the laparoscopic tower. The insufflator allows for the continuous insufflation set to a predetermined pressure. Several cardiopulmonary risks are associated with iatrogenic peritoneum, such as venous air embolism, vagus nerve-induced bradycardia, systemic carbon dioxide absorption, and hypothermia. Many patients also experience postoperative shoulder pain due to phrenic nerve stimulation. We will conclude with a discussion on common medical student roles during laparoscopic surgery, namely, operating the laparoscope and closing the port sites. As medical students tend to take more of an active role in laparoscopic cases, it is essential to familiarize yourselves with the basic procedural steps for any laparoscopic case. The surgeon will map out the port placements on the patient's abdomen after correctly positioning and sterile preparation of the patient. After installing all of the ports, the surgery can then proceed. Medical students are commonly asked to guide the laparoscope during the case. It is important to remember to keep the buttons facing directly upward, referred to as keeping the horizon flat, while ensuring that the lens remains free of debris and all relevant structures are in the frame. It is also important to keep the surgical field centered in the view. Condensation formation on the camera lens is a common issue experienced during laparoscopic surgery. It is caused by a cold metal laparoscope being introduced into a relatively warmer abdominal cavity. The use of a camera warmer can help prevent lens condensation. There are a couple of different types of laparoscope warmers that may be used to warm the scope during a surgery. A common one used is pictured on the left. It is a small cube-shaped device, often called an igloo or a mouse house, in which the laparoscope can be placed to warm and clean the scope. In addition, the ports need to be periodically cleaned throughout the case. This can be done using a large swab pictured on the right, provided by the technician. Warming the laparoscope and cleaning the port sites are roles commonly performed by surgical technicians or medical students. Please only do so when instructed. Each port site must be closed, cleaned, and covered at the end of a laparoscopic case. Port site closure is relatively simple as it involves one deep dermal suture per port, typically with a thin monofilament suture such as a 4O monochrome on a small needle such as an SH. Scan the QR code below for our full video on port site closure. After closing each laparoscopic port site, they must be adequately cleaned and covered. Typically, port sites are cleaned using laparotomy sponges and sterile water provided by the surgical technician. Once dry, the closed and cleaned port sites can be fortified using a topical adhesive such as skin glue or a bandage such as a Steri-Strip or Band-Aid. To recap, in this video we have described the concept of laparoscopy, compared its major modalities, detailed the setup and use of laparoscopic equipment, as well as explored common medical student roles in laparoscopic cases. Thank you for watching this video.